Good morning. It is my great pleasure to welcome you to the second IAD Distinguished Speaker Series on AI and Health Science. So I think the first one is a great success. So I hope that today. So it is my honor to introduce today's distinguished speaker, Dr. Yuan Luo. Am I right? Okay. So Dr. Luo is the chief into Clinical and Translational Sciences Institute and Medicine. It's okay. I think it's fine. Is this one? Hello. This work better? Yeah. Okay. Good. So a tenure full professor at the Department of Preventive Medicine at Feinberg School of Medicine in Northwestern University. So globally recognized for his leadership and significant contributions to medical AI, Dr. Luo has been elected as a fellow of the American Institute for Medical and Biological Engineering, fellow of American College of Medical Informatics, fellow of the American Medical Informatics Association, and fellow of the International Academy of Health Sciences Informatics. So a lot of fellows. I guess your next target would be become a member of National Academy of Medicine or National Academy of Science. Okay, anyway. So Dr. has been featured in eminent venues such as Economics and JAMA Network, King's Healthcare, and Reuters. Dr. Luo has given numerous keynotes to both academia and industry and has chaired multiple conferences and workshops. And Dr. Luo has published over more than 200 peer-reviewed papers, and his work has been cited by scientists across more than 30 different countries and 25 research areas. So today, Dr. Luo will talk about multi-modal for healthcare. So please join me in giving a warm welcome to today's distinguished speaker, Dr. Luo Yuan.
Thank you, Eugene, for the nice introduction. So can people hear me? Okay, that's great. So today I'm going to talk about EPIC multimodal AI for healthcare. And the EPIC is not the EPIC system that you may heard of, although I admit that's a good acronym. So EPIC stands for E, ethics, P, proactive, I, industrial, and C, collaborative. And I'm going to delve into each aspect as my talk goes on. So let's first talk about the multimodality of the healthcare data that we are working with. So I think people are familiar with all the different types of the data that I listed here. So from medical imaging to unstructured clinical notes to time series, and then to structured EHR data. And then you also have the molecular data, multi-omics, and some of the spatial transcriptomics is those emerging techniques that people might have worked with. To make all of those data generate insights for powering our decision-making in the clinical setting, we need all different specialties to work together, whether you are a scientist, basic scientist, or AI scientist, whether you're a clinician, whether you're a patient, or whether you're trainees, or whether you're an assist. So this collaborative partnership is really key in order for us to bring in our perspectives and to really make this multimodal nature data generate the insights that we wanted. So that's the first part of the C, and then I'm going to delve into the C in more depth as I approach the end part of my talk. But think about how to enable this partnership, how to mine this multimodal data. And so some of the observations that we made through our own experiences listed here. The first thing that we try to do is to enable self-service data access to researchers. This example is on clinical notes. A lot of the information is locked in clinical notes. If you wanted to extract the information for investigation, let's say you wanted to do pharmacovigilance, you wanted to understand what drugs induce what kind of side events or adverse events. And we make that available to you because clinicians, a lot of the times, they don't have the bandwidth or the expertise to launch it the NLP algorithms pipeline. What we are doing is at the health system, we took all the clinical nodes from the enterprise data warehouse. We processed them using the pipeline that we developed as shown on the right part here. And we extract those concepts like medications and adverse events. We deposit them into combinated model tables so that data from different hospitals or from even different health systems can be accessed in a uniformly way. And you can write queries to access the data mart instead of launching NLP yourself. So this is self-service data access. And two, also on data. So we talked about one institution, but really you need this kind of multi-institutional data to really bring you the diversity that you need. Think about the racial ethnic diversity, think about the geographic diversity, and also think about the practice diversity, right? So for example, some routine like bronchoalveolar lavage is routinely practiced at Northwestern Medicine, but it may not be routinely practiced in Tufts Medical Center. These practice difference can sometimes lead to meaningful differences in terms of the patient outcomes. So you want to also capture that, right? So through the initiative called Critical, which is a national consortium, we have pulled together the critical care patients data from 4 large health systems that are listed here that spans the East Coast, Midwest, and South. And for all those patients that are ever admitted into one of their ICUs, we took all their clinical data, not only just in the ICU, but also before the ICU, after the ICU stay, inpatient, outpatient, everything in the health system. We took them, de-identified them, put them in the combinated model table, and share that with the research community. So if you are interested in access it, you can search for critical, and then that will bring it to the access webpage. So you can ask your institution, university in this case, to have a representative to sign a master DUA, and then that institutional admin will be able to approve each individual users. So it's a really distributed and streamlined access model that we're looking at here. So data is one thing. Whether you're adding the multimodality of the data from the depth perspective, or you're enabling access from multiple institutions through the breadth perspective. And then tooling is another thing, right? So as I mentioned, interoperability, combinated model is one possible solution, and FHIR exchange is another possible solution. FHIR stands for Fast Healthcare Interoperable Resource. Imagine that you have a room that with people speak of English, French, Japanese, Chinese. You want them to communicate in the same language. So FHIR is sort of the English in this setting. And let every institution speaks FHIR. And when it materializes to clinical nodes, you're looking at converting this sentence into a FHIR resource that looks like the part on the right. It's like a JSON format. It specifies the medication and the reason for the medication indication and the route and timing and dosing, right? So the process of generating this FHIR resource is actually by no means trivial. And if you break it down, you started from name and entity recognition. You need to recognize what is the medication, what is the dose, and what is the indication. And then you do relation extraction. You want to classify which route or reason applies to which medication, especially if there are multiple medications that are mentioned in the same sentence. And then you need to do standardization. You can have generic names or brand names for the same drug. You need to understand that they are the same drug and then map them to the same concept. Of course, you need to do calculation, right? So the units for the dosing was not here, but sometimes the unit can be specified in different metric systems, metric or imperial system. You need to properly map them so that you're comparing apple to apples. So calculation is important. And then formatting is also important because you need to properly format this JSON-like structure so that you can ensure that the information can be sent to another part, that they can decode it in a proper way. Each of the components steps, they are error prone, and then you are compounding all these errors when cascading them. But what if we can do from an end-to-end fashion? You have a sentence that is text, you generate a JSON-like block that's also a text in, text output. What if we can use LLMs to facilitate this end-to-end task? And this is exactly why we leverage the LLMs to do this task. But to do that, we need to have other ingredients in this equation. So we have to have instructions as the prompt part that you wanted to extract those file resources from the text, give it a template of all those file resources, what does it look like, and then a few examples. So one of the benefits of the LLM models is few-shot generalizability, right? So instead of just supplying thousands of, if not tens of thousands of examples to train a machine learning model, you can now just supply 5 to 10 examples. And another aspect that you need to pay attention to is the hallucination. You wanted to mitigate this hallucination so that it's grounded in a fact. A lot of times people talk about RAG, but we found that what's more helpful is augment the LLMs with knowledge bases, knowledge graphs. And in this case, we use the SNOMED CT structure as the knowledge graph. And after this augmentation, you can really reduce this hallucination and ground all the generated file resources in the fact that is mentioned in the text and then checked out with the SNOMED CT codes and their hierarchies. So the generated file resources is again displayed here only in that I'm coloring different components so as you can readily appreciate different components as you wanted here, what goes into the file resource. To compare it with the current state of the art, we have selected representative systems from the academia, which is NLP to FHIR, and also Google's natural health language API, which is the commercial state of the art. And we also wanted to evaluate how different large language models perform, and especially with their characteristics, how that impact the quality of the generated file resource. And the result is shown in this table. If you compare LLM performance with these existing NLP pipelines, the SODA currently, you can see that those LLMs mostly outperform the either academia or commercial SODA by a comfortable margin. And then if you compare across different LLMs as the backbone for the file generator, something interesting emerges. If you look at the size of the parameters, Llama 2 has 70 billion, and then Falcon 180 billion, GPT-4 has 1.7 trillion. And you also see the corresponding increase in terms of the performance as the size grows bigger. So size does matter, but it's not linear increase, right? So this gives an interesting consideration, especially when you want to operationalize the file resource generator. So let's say for GPT-4 compared with Falcon, gives you like 0.05 AU's F1 increase. But GPT-4 is on cloud, is not, it may not be HIPAA compliant with your institution, but Falcon is locally deployable and it's open model, right? So, and the cost-wise is much cheaper, so it's like 3 times or even more costly for GPT-4. So when you do operationalize it, you want to trade off this accuracy or F1 metric with this security consideration, with this cost consideration. And then tooling, not only just the touches EHR, but also you want to develop this kind of tooling that allows people to analyze molecular data also in a self-service fashion, right? So this is why we developed this resource SOAR, which is spatial omics analytics resource. It's not just the data set, although it's the largest data set so far on spatial transcriptomics, especially with human samples on different disease. It's also a resource that lets you do meta-analysis and mega-analysis. So for people who are familiar with single-cell RNA-seq, spatial transcriptomics lets you understand the single-cellular activities within the tissue context. When the immune cells and malignant cells, they are close in the tumor microenvironment, or when they are farther apart, how their activity changes in response to that. Right? So you can imagine all sorts of useful analysis that, and we provide them with SOAR, right? So with spatial variability analysis to look at the gene expression across the different areas of the tissue, to look at the cell-cell interactions like the immune and malignant cell interactions in the tumor and immune microenvironment, and then differentially express the genes across different cell types. That would give you understanding of the disease mechanism. And we further overlay on top of that the drug perturbation data we can fuse with the mechanistic data so that we can help you prioritize the molecular compounds that could target the specific cell-cell interaction and differentially express the genes in the diseased tissue. So that gives you a really nice way of looking at what molecular compounds you want to push down to downstream development, preclinical or clinical. And to do that, we address the challenge of the current data being really heterogeneous and fragmented. So just to think about the landscape, we have about 20, or actually even more than 20 spatial transcriptomics techniques out there. Even when people publish on the same techniques, their data can be subject to different quality checking, quality improvement protocols. And then their cell type annotation pipeline could be very different. So what you call a T helper 1 cell, Th1 cell may be different from what he called a Th1 cell. We wanted to unify that language and unify all these quality checking criteria and perform the consistent cell type annotation and deconvolution so that meta-analysis and mega-analysis would be easily doable with aggregated data. So this is something that we found through our analysis that aggregate different breast cancer data. Actually, it's pan cancer. So we found something interesting in terms of the disease mechanism regarding the axis of the CXCL pathway and SPP1 pathway ratio in macrophages. So CXCL is pro-inflammatory, and SPP1 is sort of anti-inflammatory, pro-tumor growth, and pro-metastasis. You see that macrophages that are positive for CXCL9, they interact CXCL16, they interact with CXCR6 positive CD8 T cells. And then these CD8 T cells that are positive for CXCR13, they interact with CXCR5 positive B cells and also CD4 T cells. Right? So it's kind of a cascading action in terms of triggering the anti-tumor environment here. On the other hand, if you look at the SPP1 pathway and then the macrophages that are SPP1 positive, they interact with this integrin alpha V positive fibroblast, endothelial cells, and malignant cells, right? So, and this interaction sort of is pro the metastasis and tumor seeding. On the other hand, these macrophage cells also interact with the CD44 positive mast cells, and that interaction hinders the mast cell's ability to activate the inflammation. So again, this interaction is anti-inflammation. Right, so now you can see that CXCL pathway and SPP1 pathway, their ratio on the macrophage cells is sort of acting like a rheostat. The rheostat that you can dial to the one spectrum or to another extreme, and then that can control the activities for anti-tumor versus pro-tumor. And so this is something that speaks to the mechanism. And within the tumor and immune microenvironment, we have also identified druggable targets that, especially with people that are not responding to first-line medications. And this example shows the ulcerative colitis, which is a form of IBD, irritable bowel disease. And we can see that those tissues here, these healthy colon tissues, this is from the patients with UC, but they respond to the first-line medication, vedolizumab. And this one is the patient with UC, ulcerative colitis, but not responding to the vedolizumab. And you can see clear disruption of the epithelial structures here. Analyzing the spatial transcriptomics data from those samples, we found that those non-responders, they have higher ratios of the T cells and, as you can see, T cell NK cells and myeloid cells. And analyze the expressions of all the genes, looking at the differentially expressed genes, we have also see that those non-responders have higher expression of the JAK-STAT pathway genes, as shown here. And so this started to let us zoom in on these possible JAK-STAT inhibitors as a way of combination therapy. And if you look at this panel, this drug we applied here is fedratinib. You can see that it mitigates the differential expressions on the T cell, NK cell, and myeloid cells, but it sort of let the other non-immune cells intact. So this is kind of interesting to suggest that the fedratinib would be a candidate for combination therapy for the people that are not responding to vedolizumab, that those UC patients, ulcerative colitis patients, right? And in fact, this fedratinib is actually in clinical trial as a combination therapy paired with the vedolizumab, right? So what we found is that coincidence with the currently ongoing clinical trial. And so that is interesting in terms of offering the possibility of suggesting molecular compounds that could help you target the mechanisms of the disease and also mechanisms of the disease that are not responding to the existing medications. So it just opens the more avenues towards the combinatorial therapies for diseases that are particularly hard to treat. And spatial transcriptomics is useful, and the resources are useful not only in terms of helping you understand the disease mechanism, to target the mechanism to develop effective therapies, but also in terms of thinking about the healing process, thinking about the tissue regeneration process, right? So imagine that for a patient with fractured skull, you may want to plant a scaffold to help the patient's healing process, right? And the scaffold, you can design different parameters, whether it's the material of the scaffold, or whether it's the pore size of the scaffold, or whether it's kind of the hormones or the chemokines that you want to release in order to recruit these progenitors to the central defective area. All those are parameters that you can design. How do we know that which one works, like sort of in microscopic view? And instead of waiting too long, then we find that it may work or may not work when the patient have already suffered multiple days of the treatment, right? So this is where we're looking at the spatial transcriptomics to really help you zoom in on these defective areas and then look at the kind of cellular composition and the gene expression patterns, and to see which cells are recruited to the central if defective area. And you can see that with this composite material, that we were able to recruit the osteoblast to the central defective area. And for the, and if we do not have that composite material here, then the osteoblast were mainly grouped in these areas that's on the brim, on the rim of the fracture, rather than the central defective area, right? So it's actually not the absolute number or quantity of the osteoblast. It's actually their location that really spells the prognosis of the healing for the patient. And this is illustrated clearly with this spatial transcriptomics technology. So now we have talked about the data that needs to power this multimodal collaborative AI, and then the tooling that looks at the EHR side, the molecular side to power this. And let's try to bring it together and then really see how it can do when we really have all those data modalities layered on top of each other. So in this paper, we're looking at autism. And for all of you who saw Rayman, I think Dustin Hoffman did a fantastic job in terms of demonstrating what on your speech and repetitive behavior and the kind of behavioral patterns of autism, which is right now still the gold standard for diagnosis. But this behavioral-based diagnosis is problematic for screening and early intervention of autism because when the child is diagnosed, they probably already 4 or 5 years old, and the critical intervention window has already gone by in order for the individuals to gain more functional independence when they grow up. What if we can move the early diagnosis back to when the child was just born, right? What if we can develop biomarkers to do that? And this is our purpose of doing this research. We know that genetically autism is hereditary, and then we know molecular diagnosis will be a promising path, but it's also a very challenging path. And because we have so many distinct variants across each of us, even if it just speaks about whole transcriptome, how do we know that those thousands of distinct variants, which one of them underlies the disease? To do that, this is what we devised, and we leverage different modalities of the data. The first one is the transcriptome, and we have for individuals, different individuals, their RNA-seq data for the brain development across different times, and of course across different times is from different individuals, their biopsies of the brain, and then we took the expression measurement. This gives us the trajectory of the different genes, how they are expressed, and then we can leverage this expression pattern to find those that are co-regulated during the brain development. And this co-regulation gives us the possibility of clustering them together. These axon clusters, they really serve as a hinge for improving the power of the study because you are not looking at the mutations individually. You're starting to look at the mutations that hit any of the exons in the cluster, and then you can aggregate them, right? So think about the spaces as being reduced. And then through these aggregated mutations, you improve the power of the study with even the same samples that you have. And of course, for the samples, we have the different families, right? Discordant families where you have multiple children, 2 children, one with autism, one with not autism, so prevent and control. And then with multiplex families, you have multiple children, all with, from the same family, all with autism. So you can imagine that if you look at the differential mutation from discordant families, and then look at the shared mutations from the multiplex families, that help you to further narrow down the candidates of the disruptive genes. And of course, we have disruptive. We want the genes, the mutations to be disruptive or deleterious so that they have a more drastic impact on the functions. Right? So all these data help us to form the molecular hypothesis. And then we can validate that in the EHR data and with even bigger insurance claims data set. So that's an overall study design. And some of the interesting findings from the clusters that mutations will be implicated in the autism development include the clusters that are related to the LDL receptor and then the lipoprotein lipase cluster as well. And we also have larger clusters, much larger clusters that involve more of a mechanistic spelling or illustration of the process. So for this one that I illustrated here, you see that the LPL, they help digest the triglyceride-rich lipoproteins and then produce the LDL particles. And then the LDL receptor on the cell membrane, they internalize these LDL particles for downstream development, for downstream chemical reactions that are instrumental in the brain development. So you can imagine that what if the LPL and LDL receptor got disrupted, then we would be left with abnormal amount of triglyceride or LDL in other molecules, and we can validate that in the real world data, right? So looking at the LDL total cholesterol and triglycerides from the EHR data, we find that they have significant odds ratio when compared autism children with non-autism children. And this holds true after we have stratified and then controlled for confounders like the age, gender, and their comorbidities. We further took it to the insurance data, which is even larger, and then we look at the diagnosis code for the different abnormalities associated with dyslipidemia. Again, they are significantly enriched in ASD individuals. And also we controlled for the confoundings like the atypical antipsychotics and anticonvulsants and antidiabetics, which a lot of the autism children were taking, and those are confounders. After we have controlled for those confounders and excluded those individuals taking those drugs, you can see still we have significant difference in terms of autism individuals versus non-autism individuals. What's more interesting is that we look at the fathers and mothers of those children with ASD and without. And then we found that some of them have high enrichment in terms of those dyslipidemia codes. And this further suggested that we may be able to even perform the blood test on those parents during the pregnancy in order to help move the intervention, the screening window even earlier. Actually, probably the earliest as possible. And I want to stress the importance of the complementarity of all those modalities that you overlaid here instead of just the absolute size, absolute volume of the data. I think what's more important is actually the complementarity of all those data sets. Each, they give you an angle or perspective of the mechanistic or theory, but triangulate them lets you pinpoint, zoom in, and really narrow down on the most likely causes of the disease and the biomarkers that you can use. So that was on the disease understanding part when you're bringing everything together. And similarly, for the drug discovery part, we can also bring everything together. So in this paper, we were actually targeting the drug repurposing problem for COVID-19, where back then there was no effective treatment. And the thing that we did is to look at the protein-protein interactome. And this is actually between the virus and the host. Right? So you can see that we can identify those host targets that are shown here. And again, overlay that with the drug perturbation database. We can identify the molecules or compounds that would be effective in terms of blocking those host targets that are impacted by the viral protein. Once we have identified these candidates, we can validate that using our real-world data from the EHR. And in this case, we're looking at carvedilol, which is actually used by quite a lot of people. And we can look at their relative severity of the disease and onset of the disease when compared to people that are not using them. And you see there is quite a big of a difference and quite significant across both male, female, and different racial ethnic groups of the patients. So that is real-world evidence. And we further overlay the experimental data on top of that. So we actually performed the wet lab experiment for a human lung cell line that's infected with the SARS-CoV-2 virus. We experimented with different dosage of carvedilol and then portrayed the effective dosage curve and then toxic dosage curve. And clearly you can see that there is the big Goldilocks zone here that is the dosage that will be effective but not toxic. And note that this scale is logarithm, so that it's so the range here is actually quite a comfortable range. So that gives you an overview of those multi-modal data when you collaborate with different partners about their specialties, whether in wet lab or whether in protein interaction or whether in EHR, real-world analysis. That can give you the more comprehensive understanding that will power the drug discovery. And now let's take a step back, and then although we have this really powerful data set and algorithm that lets you drive the discovery and inform the intervention, those AI algorithms, they need to be ethical. And in this, I'm going to illustrate why we need to pay attention to this. Of course, ethical is important, then we want all of our algorithms to be ethical. But more to that, algorithm can actually help us to identify the hidden disparities that we may have not noticed. And in this study, we looked at the critical care resource allocation protocol that were in effect in the early days of the pandemic. So you have those lottery protocols and youngest first protocols that are really pragmatic. And they were actually used, the youngest first was actually used in Italy during the early phase of the pandemic. And then in the US, you have also state protocols that are based on SOFA score, which is a acuity measurement of the patients, and the scores that mix the multiple principles, acuity, comorbidities, and even age. By the time that they were being used in the different states, there is little evidence on whether they actually are fair or not. Despite that, they intended to be fair and they didn't mean to penalize any special patient groups. So this is why we wanted to fill in the gap of the missing critical empirical evidence. And then we took the data from 2 tertiary care hospitals and a community hospital network. These data reflect patients of different racial ethnic compositions, and then the outcomes are also quite different in terms of the length of stay and mortality rate. And so it's quite diverse patient populations that we're looking here, and then we did simulation based on the usage of different protocols, and they wanted to see if those protocols would give patients the comparable amount of resource allocation across different racial ethnic strata. This is what we found. In terms of the resource allocation, it's on the left as shown here. So lottery, of course, is fair, absolute, equal in terms of the amount of allocation. And we are simulating a 50% scarcity rate. And then youngest first, you see there is difference, but primarily it's because the age of the patient groups. So in our population, we have Hispanic people which are younger and white people which are older. So that got reflected. But then if you look at SOFA only and multi-principal allocation protocols, you see that Black patients, they consistently receive less ventilators in the healthcare setting. And this translates to lower survival rate on the right. So we ask why, because those protocols, they never took the race ethnicity as a variable. They didn't intend to penalize any specific groups. So what we found out is that actually Black patients came into the hospital with higher comorbidities and higher acuities. And this is part of the existing healthcare burden from their previous interaction with the health system. And if your product only relies on those security and comorbidity principle, and they inadvertently captures the disparities that are already in there and then exacerbate it. So this is why it's important to have the algorithm, data science, or AI to give you the empirical knowledge that whether something is ethical or whether something that there is hidden disparities that is unnoticed. Right? So once we have identified that, we can develop algorithms to combat the kind of disparity in there. So this is the follow-up work that we did, and it's a reinforcement learning algorithm that tries to trade off the principles of saving maximum number of lives that we wanted versus giving comparable allocation of the resource to different racial ethnic groups. Right? So here we have modeled the patients and their evolution in the ICU on a daily basis. And we want to learn a policy that given all the patient states, we take actions of giving them ventilators or not giving them ventilators. And key to that is actually predicting which patient is going to survive with ventilators and which patient is going to survive without ventilators. So you have all these probabilities here. And to do that, because it's really complex prediction and policy learning task, we use the transformer-based backbone for learning that policy and making the prediction. And of course, for the objective functions, we wanted to have two components of the objective function. One is to maximize the numbers of lives that we save. We still want that. We still want to save more people as we could. Two is to balance the allocation ratio to different racial ethnic groups. And can we achieve both? And especially compared to current state protocols, right? So here is the result. So if you are looking at lottery, all of the patient groups roughly have the same curve regarding the allocation rate as the ventilator capacities increase or decrease down to zero. Right? But then if you look at those protocols, youngest, first, so far only multi-principal ones, and you see that they started to diverge apart, which means that they get very different allocations at different ventilator scarcity. But then for our system, we were able to pull them back together, meaning that across different scarcity levels, those different racial ethnic groups are still going to get comparable amount of resource allocation. So I think we checked the fairness metrics. But what about the total utility? So here we give you survival rate at different racial ethnic capacities for different protocols. It's the overall survival rate and then also allocation rate. You can see again our system traces on the top frontier as you vary the capacity or scarcity levels, which means that they gives the max number of patients saved compared to the different protocols that were used in different states and countries. So here we demonstrate that you can balance and attend to both the utilitarian and egalitarian perspectives. And especially if you have algorithms that lets you attend to different dimensions of the data, which is hard if you wanted to look at it by human because we have difficulties in attending to more than 7 variables, right? So in ICU, you have like hundreds of the variables coming at you at a constant pace, right? So reinforcement learning algorithm could be really helpful here to balance all this information that comes into you and also to balance the different objectives from the utilitarian and egalitarian perspective. So imagine that in the future that you're going to be able to develop this kind of virtual cell and then simulate the interactions of the cells in the tissue context and try to illustrate the organs, their functions or dysfunctions based on the tissue mechanism that you're modeling. And that translates to insights to individual level, patient level, and to patient level. So that will be something that is very exciting, that we're building those virtual cells, digital twins about organs and tissues and individual patients. And I'm claiming that it's going to be tangible in at least 5 to 10 years. But what we need to do to take it to there, right? So we already talked about multi-modal data, that's the foundation. And we already talked about collaborative AI. And we already talked about ethical AI. Those are all the foundations. I'm claiming that we still need to do 2 more things. And one is proactive AI, in the sense that AI algorithm now is not what it used to be, that it solely receives the input from the humans. It needs to be more proactive. It can help us to identify where the weakness of the data is, right? So you have all those data drifting and shifting issues if you just treating AI as reactively taking human inputs. But with the proactive AI, you can let AI algorithms tell us where the weakness of the data is, where the biggest missingness is, where the bias is, like what we showed when we illustrated the ethical usage. And then in this setting, from the bench to bedside, people used to think about it's a unidirectional workflow. From the bench to the bedside, you have a molecular hypothesis, you develop a compound, you push it to clinical study, you use it on the patient, but it's actually not unidirectional. When you use them on the patient, you can observe the unmet need at the healthcare provider level. Think about the example that ulcerative colitis patient does not respond to vedolizumab, then that unmet need can be transferred back into the bench side. That prompts you to refine your hypothesis, like trying to find other candidates, like the fedoratinib, like I showed in the panels, that could be used as a combination therapy candidate. And that makes the bench to bedside not a unidirectional information flow, but a virtuous feedback loop, right? So once we have the proactive AI, we can really power this bench to bedside feedback loop. And the AI algorithm based on the existing data could tell you where's the next high value experiment that you can do. You collect experimental evidence. That evidence will feed it back against to the model and to improve on the model. So this virtuous feedback loop is something that will be really powerful if you can drive the flywheel with the proactive AI. And we can also leverage proactive AI to develop agents that let us integrate different modality of the data, from the structured EHR data to the unstructured clinical notes, because a lot of the times they have correspondence among each other. Imagine that those agents, they can map the tokens in the node space, in the structured EHR space, into the same embedding space, and they can perform joint reasoning on that space. So that will be able to help you to better complement each data modalities and perform joint reasoning, and then give you insights directly from the AI so that it is more proactive. And of course, through reinforcement learning, we can leverage it to improve the operations. The example that I showed you with RL for more equitable healthcare resource allocation is just one example. It's part of the operations of the health system. You can also imagine that we can leverage AI to make it more cost effective. For the diagnostic process, we could maintain the same levels of the diagnostic accuracy, but reduce the test costs. A lot of the times physicians were based on the reflex ordering protocol, order a large panels of the test. Not all of the variables are used. We can resort to smaller and more cost-effective panels while still give you the sufficient diagnostic information. So, and this has been demonstrated in a paper that we did before. And the second ingredient that we need is industrializing AI. I'm talking about deployment, scalable deployment. That's one dimension for being industrial. So in this example, we have partnered with a company, ClearStep, that my postdoc is a founder. And then we have deployed LLM to touch all the patients from across 50 states to help with their navigation of the health system so that they can, based on their symptom, query with our LLM and then land with the bookable appointment with a health system that is accessible to them. Industrializing AI also means that marrying emerging technologies. For the tissue regeneration example that I mentioned before, so AI can help with the design of the scaffold so that you can optimize the healing by recruiting more progenitors into the central defective area. You can also reduce the fibrotic process so that's to reduce the excessive scarring during the latter phase of the healing, right? So, and with the effective partnering between bioengineering and AI, I think we can do this at scale. And industrializing AI also means that to complete its own industrial revolution. We now have such complex AI system that not too many people would be able to master it as a full stack developer. But we can draw inspirations from the previous industrial revolutions where you see assembly lines, all those manufacturers, the workers, they don't need to be able to know how the car was made from the scratch. They all need to be just mastering one component of that assembly line, and then together they will work to make a car. So similarly, for AI systems, we can, each one of us, whether you are a physician, whether you are a data scientist, whether you are a basic scientist, we can master one piece of that component in the what I call assembly network because it's more complex than assembly line. And together, we will be able to make it a whole piece so as to whether care for the patient or develop new drugs. To do that, to really industrialize AI, we need to develop the education and mentorship to grow the next generation talents. Right? So this is why we help to launch initiatives like Healthcare AI Forum that I show here. The idea is that there are so many advancements every day. It's really hard for people to keep up with pace. What if we provide those short and bite chunk video tutorials that gives you the intuition and lets you understand how you can embed that into your own daily workflow? So this is actually very well received from the university, so that we later expanded to cover the greater Chicago area, other universities and industry, pharma and insurance companies. And last year, we further expanded this initiative to the nationwide. So we have universities like Stony Brook on the East Coast and Emory on the East Coast. And also in the Midwest, we have Wisconsin, Madison, Ohio State. And then in the West Coast, we have UCLA partnering with us to expand the healthcare AI forum to deliver more of those state-of-the-art developments in intuitive fashion and as a takeaway message of how to integrate that in your own daily workflow. And another initiative to train the next generation talents and enable them to work together is the AI for Health Clinic. Here, we were observing that clinicians and AI scientists not always work well together, right? So there have sometimes been doubt and sometimes even been distrust among those research communities. What we found really helpful is that to enable them to have this whole journey partnership. From the idea inception, a clinical challenge, they can pitch to the clinic, and the staff and the trainees could help the clinicians to brainstorm ideas, to debate about possible solutions, and actually implement them. and deploy them in a health system and perform continuous monitoring and improvement. This whole journey partnership lets each community to invite each other's perspective to enrich their own. This serves sort of like a venue for cross-pollination, clinicians and AI scientists. And this has proven to be really working well, and not only developing good rapport, but very effective in terms of developing the technology. And that leads not only to systems that are deployed, but also leads to sustained federal fundings from the NIH, from the R grants to U grants to center grants. And also, I've started to deliver those year-in reviews about AI and data science in the healthcare field, and in a way to, especially for the AMIA community, to let them to grasp what the latest hallmark development for each year. In the end, it all boils down to successful team building and execution to power this epic multi-modal AI vision that I proposed. And I mentioned that bench to bedside is an iterative journey and as a feedback loop. But with collaborators and partners, we were able to drive that flywheel and then to take it to the next level. And some of the pillars that along the journey we need to develop is, one, integrate that into the R&D value chain for the health system and develop the workforce, as I mentioned, for training the next gen talents and strengthening partnership and grow our infrastructure. This is important, ever more important in current dynamic and somewhat crazy time that we are in. And then, of course, research excellence and innovation is always the key for academic medical centers like Buffalo here. And we wanted to be a hub for national AI collaboration. And this could be from different CTSAs, this could be from the different academic medical centers. And more importantly, I think each of us is good at something different, right? So we could leverage our strengths and then extend our partnership and collaborations to others, right? So that's the sort of assembly network notion now manifests itself as a national network, right? Through all those ingredients, we'll be able to really leverage this epic multimodal AI to power this bench to bedside feedback loop. So with that, I'm going to close with this open invitation for letting us work together and then take this to a whole new level. Thank you.
Thank you for that excellent talk. And I really appreciate that you presented your own work. I mean, some people get up and they present the field and lots of people's work. This was really all your work, which I think is fantastic. Fewer people are really doing that these days, and I really appreciate it. So I have two questions. The first is on the first piece of work in NEGM AI. You know, the field is moving fast and the new models are coming along regularly.
Right.
Have you tested Llama 3 or Gemini on that data set to see how they performed compared to GPT-4? I don't know if you didn't. Then
Yeah, I think we tested Llama 3 as they came about, but I don't think they are, at least not significantly better than GPT-4. And then Llama 4, I think it's probably a little bit worse.
oh yeah, they did, and that's because of the training the images, I think.
Yeah.
But the other question I had was, and this is a more tougher question, you know, you gave this talk about normalizing the predictive value for the population based on race and ethnicity, and I wondered if you were concerned at all about causing harm. And the reason is that if you are actually predetermining the rates of whether someone's going to get a ventilator before they come in the hospital, not based on their presentation, you may actually take away needed services from people who actually need it and give it to somebody who's less needing it. Because in the first slide where you had it, you saw that the the rates of ventilation in, I think, the African American and Hispanic populations were higher. And then they normalized, they came down in the normalized graph that you had at the end. But I worry about, taking the clinical judgment out of it. And if the population, in fact, is a sicker population to begin with, it may be correct that they get a higher rate of ventilator support. I wondered if you could just talk about that for a second.
Well, actually,
I worry about these things.
Yeah, actually, I want to clarify on the reinforcement learning study that we did. We're actually taking the clinical manifestation into account. So our system starts work at least after day one, that we have at least 1 day observation of the clinical manifestations in conjunction with the racial ethnic profiles of those patients. We don't want to let the system work from day zero. Yeah.
Thank you.
Sure.
Thanks again for a great talk. I totally agree with Peter. It was really nice to see. And it seems like a very realistic view of the next years. I kind of want to double down on Peter's question too, though, because I'm very pro this stuff, but I read a lot of Isaac Asimov as a kid. And, the fact that you talked about the ethics, I think, is really important. And what I think is potentially missing a little bit, though, is transparency as well.
Right.
So we get these deep learning systems, and we're seeing now that a lot is kind of congealing around LLMs as a central technology for this, but they lie about the way they're reasoning and their reasons for doing that. So,
Right.
Kind of the same as Peter's asking, how do you see that we can kind of not just optimize objective functions, but ensure that as we become more agentic, that these things kind of align with basic human values? Are there more transparency things we can do for that?
Yeah, so actually, I think this is a really great question. And of course, you know that LLM lies about their ways of reasoning. And then you saw the paper that talks about chain of thought is actually misguiding. And this is why I think that in addition to the dialogue system nature that we get the sort of narratives from the LLMs, we still need to take a look under the hood. What are the actual weights it's actually using to make those decisions? And the fact that a lot of those LLMs, they are based on this attention mechanism is kind of making it more convenient for us to really look at all the weights that are used across the different layers. And so I think a combined approach that looks at the under-hood weights coupled with the thing that the language model that is telling us is a step forward. And if you really think and compare that to how we interact with humans, right? And we interact with one another solely based on at least mostly based on our conversations. The doctors tell you their reasoning process, but can you be 100% sure that the doctors is being 100% forthcoming with you? And then in this case, we actually don't have a way to peek inside the doctor's brain to look at the weights. But we do have a way to peek inside the LLMs to look at their weights. So I would say that we're actually maybe a little bit better when we are looking in a better situation when we are looking at interaction or trying to be interpretable among each other.
So this is the automated cars driving problem when you say look at what human drivers do.
Yeah.
Yeah, okay, it's a fair point. Thank you.
Sure.
I just wanted to add on to that, if that's okay.
Mhm.
I know we use Shapley curves, and then now I found confrontational models to be very helpful in trying to understand how the machine is thinking. And the other thing we've done, which we think has been very helpful to us in explainable parts of the AI, is we've actually asked the AI to prioritize things based on its own data model, since you don't know what it was trained on. And not only did it give us very specific insights into the training data, but in addition, the format in which it spit it out told us a little bit about how it does implication inside of the model. And I thought that was I was pretty blown away by that. And it actually made us feel like we had a way to start to learn more about deep learning models and be able to give explanation to people who are interested in knowing how the model made its interpretability. And before we were doing that, we simply created a Bayesian net alongside it and figured it couldn't be too far off from the Bayesian net, which was completely explainable. And nobody really liked that we did that. It was kind of a side, going to the side of the issue rather than taking the issue right head on. But for us, we wanted just to know. And I think you're right about doctors, although we do understand a lot about medical education, and we spend an awful lot of time, and we're now starting to become a thread, informatics as a thread in the whole medical school process throughout all the courses. And so we're trying to make more explicit the kind of reasoning, how we teach reasoning within inside of the medical school. And I'm hoping that that helps to solve your problem that you can't look inside the doctor's brain. Certainly we have lots of neurosurgeons, but we don't advocate that. But we do want to understand exactly how we both formulate medical education, translate it, and evaluate it in ways where we can get a consistent and excellent educational outcome from our students. And that may go a little bit of a way to make you feel more comfortable about the human part of this. Because I don't believe, Bill Gates said that there won't be doctors in 10 years, they'll just be AIs. I don't believe that. I think there's a lot of things about humans. I mean, AI cannot give me a hug when I'm feeling down, I mean, I think, and I don't think they'll have empathy the way that a person can have empathy. So I don't really think doctors are going to go away. But I do believe that a doctor who uses AI may replace a doctor who does not. And anyway, what do you think the future is going to be of AI in health?
Certainly. Peter, I totally agree with you. And I forgot to mention that, Shapley plot is another technique that many people, including us, also uses a lot when we wanted to improve the explainability of the system. And also, I agree with you that what you mentioned, like lets AI to really act on its priorities. I think it's a clever way because even for humans, right? So don't just listen to what he says and just look at what he does, right? So it's always a good way to find the true motivations, right? So this is a clever approach for sort of letting AI to reveal what is the main agenda, real agenda, right? And in terms of the future, it's interesting that you mentioned Bill Gates' prediction about AI, and that reminds me about the other people's prediction, like Jeff Hinton predicts that AI is going to replace radiologists, and Elon Musk predicts that automated cars are going to replace human drivers. And then lately, I saw a meme saying that probably in a multi-lane street in LA, and then there are many radiologists that are driving their cars that stuck in traffic to their work. So nothing of that prediction of Jeff Hinton and Elon Musk happened. So I think in the future world, you're right. I think physicians who is using AI is going to replace physicians that are not using AI, and probably applies to other specialties and industries as well. And I would be very happy to see a co-evolution of humans and AI so that we can talk to the AI, we can ask AI to help us, and AI can help us to help them, right? So think about the MCP, like model context protocols. AI is already being able to call other codes, even connects with the 3D printer to do things for them. What if they can also be connected to physicians and humans, right? So a lot of the times AI needs us or physicians to do chart reviews for them, to label additional training data, or to tell them if there is bias in the model, right? So and even for study coordination, a lot of the time study coordinator may be asked upon to act on the problematic recruitment status, right? So what if this can go into a central planner? So all those different threads that would be really difficult for humans to juggle, but with a central AI planner and with something like MCP enabled assembly network, that we can really seamlessly work together in a mutual direction. It's not just the one-way road from a human asking AI, but also AI can ask humans. Then we would be really in sort of a symbiotic relationship. So that's what I would like to see.
I'll ask one more. You said something really interesting at the end there about the embedding. I'm curious. You started out with the LLM translation to Fire, which is really interesting. Do you think Fire and those kind of things are the way to go, though, or are they more of like a weird compromise between humans and machines? I guess what I'm getting at without just the whole vector embedding thing has been really an amazing engine to put things in this kind of higher semantic space that lets you link concepts. And is there a better embedding space that we should all be working on building together for medical concepts in terms of the way drugs are working, the way timings are working, the way symptoms are working, that would help kind of drive the technology forward?
Right, so I think that's a good question. And then, so for embedding, I would sort of put it on a unstructured form because you don't know exactly which dimensions of the embedding corresponds to what concrete actions in the real world, right? And with Fire, it's more of a structured manifestation of the things that you really wanted, right? So, and of course, from a purely computational perspective, a shared embedding space with all the embeddings probably would be just sufficient and good enough for end-to-end computation if that's all you cared about. But then you also cared about the interpretability and then how humans would be able to be still in the loop, right? So that needs structure, right? So I think it's going to be a hybrid of those two, right? So,
Yeah, that's kind of what I'm asking, if there's a happy medium somewhere between there.
right. So at the bottom computational layer, it's probably embeddings on the crunch, but at the top layers, and then especially when it's human input and human actions, it's more of a structured, whether it's Fire or whether it's MCP, that still would provide a meaningful interface to humans. And even in natural languages, some sort of structured representation of the word that sometimes otherwise may be purely embedding. I don't know.
Yeah, thank you.
Sure.
Barack from Zoom says, great presentation. I would be grateful if you could briefly explain how you combine proactive AI and knowledge graphs to interpret multimodal data in healthcare.
So I think this is something that would require iterations, right? So knowledge graph, as we know, a lot of the times they were built by humans. And there is insufficiency of those knowledge graphs, right? So the current SNOMED CT, the current ICD 9, 10, they are imperfect. And of course, some of the more complex knowledge graphs, whether it's in the molecular space or whether it's in the phenotype space, they are still imperfect. And even our understanding of the biology is imperfect itself. So knowledge graphs needs evolution. And of course, this is where proactive AI can help, right? So what if, like in the loop of more experiment, refine a knowledge graph, and then to drive the next round of the experiment, we could insert AI, inject AI into that loop to help us to identify the weakest link in the knowledge graph so that we can plan our next experiment to collect the empirical evidence to perfecting that link and then to expand beyond that, right? So it may also help us to identify where is the next biggest opportunity for discovery in that knowledge graph so that we can put our resource towards that directions of the research, right? So I think there is tremendous opportunities in embedding proactive AI. So letting us or informing us on those opportunities that otherwise would be hidden or otherwise would be difficult to find by just the humans, because we are fundamentally limited about the dimensions that we can attend to at a single time point. But those AI algorithms doesn't have to be subject to those limitations. Let's give it up to another round of applause. Thank you.